Acute thoracolumbar spinal fractures. Most acute thoracolumbar spinal fractures are located at the thoracolumbar junction. The first step in therapeutic decision making are classification of the fracture according to its morphology after doing an investigation. Plain radiographs in combination with the CT scan allow proper classification in the majority of fractures. MRI is helpful to determine the status of the posterior ligamentous complex in uncertain cases. Dennis 3-column system. Anterior column, it includes anterior longitudinal ligament, anterior 2/3 of the vertebral body and annulus. Middle column includes posterior longitudinal ligament, posterior 1/3 of the vertebral body and annulus. Posterior column includes pedicles, lamina, facets, ligamentum flavum, spinous process, posterior ligament complex. Dennis classification of vertebral fractures. Type A, fracture of both end plates. The bone is retropulsed into the canal. Type B, fracture of the superior end plate. It is common and occurs due to combination of axial load with a flexion. Type C, fracture of the inferior end plate. Type D, burst rotation. This fracture could be misdiagnosed as a fracture dislocation. The mechanism of this injury is a combination of axial load and rotation. Type E, burst lateral flexion. This type of fracture differs from the lateral compression fracture in that it presents an increase of the interpedicular distance on an anterior posterior X-ray. Defining the stability of the fracture is very important. The fracture is defined as unstable if there is an injury to the middle column or a disruption of the posterior ligament complex combined with anterior and middle column involvement. Coming to the treatment, conservative treatment is indicated if the patient is neurologically intact and mechanically stable. Posterior ligament complex are preserved, kyphosis less than 30 degrees and vertebral body height maintained. That is more than 50% of height maintained. These two, kyphosis and vertebral height, are controversial issues in the treatment. But if the patient is neurologically and mechanically stable, we can treat them conservatively. Brace versus no brace in conservative treatment. Conservative treatment includes early ambulation, adequate pain medications and physiotherapy. Frequent radiological examination can reveal the treatment failure at an early stage. Orthosis don't play an important role in conservative treatment according to the study published in Spine 2014. Indications for surgical treatment. Clear indications for surgical treatment are unstable injuries with the failure of all the elements leading to dislocation or a translation or a displacement in any plane. Further indications for surgery are complete disruption of the PLC or neurological deficits due to ongoing compression of the neural structures. Surgical versus non-surgical treatment for thoracolumbar burst fractures without neurological deficit. There is an ongoing debate whether to operate on a complete burst type of fractures without neurological deficits. Treatment of these fractures varies considerably between geographic regions and ranges from conservative treatment to combined anterior-posterior surgery. One small randomized trial with a long-term follow-up suggested that non-operative treatment yielded less pain and better function. However, due to lack of large prospective randomized studies, the definitive optimal treatment of thoracolumbar burst fractures without neurological deficits remains unclear. Compared with the anterior approach, the posterior approach demonstrated superior canal decompression. Surgery types. Posterior spinal fusion alone with or without decompression. Anterior decompression and stabilization. with or without posterior stabilization. Posterior decompression and stabilization. Posterior decompression, stabilization and fusion. Posterior corpectomy, ventral decompression, cage and instrumentation. That is 360-degree fusion. These are different types of surgeries done for vertebral fractures. Nowadays, surgical treatment is typically performed from the posterior side because it offers better fracture reduction, canal decompression, and less blood loss compared to the anterior approach. Today, short segment fixation is the preferred method of stabilization. The additional application of short fracture lever screw can enhance stability in severely comminuted fractures. Anterior stabilization alone or in combination with the posterior stabilization may play a role in certain cases. Fusion or no fusion. Fusion may not be necessary procedure for surgically treated burst fractures of the thoracolumbar and lumbar spines. A follow-up 10-year study published in JBJ's 2014 questions the fusion. Coming to the complications, neurological deficit, entrapped nerve roots and dural tear, pain, progressive kyphosis, flat back deformity. Conclusions: thoracolumbar fractures are common in T10, 11, 12, L1, L2 area. Stable no neurological deficit, conservative treatment can be done. Unstable neurological deficit, surgery. Nowadays, posterior surgery is common.